Intrapartum fetal surveillance. So factors affecting fetal oxygenation in labor. ಒಂದು placental blood flow and umbilical blood flow. If when on uterine contractions ಏನಾಗುತ್ತೆ, the blood flow will be less. ಪೇನ್ ಇರುತ್ತಲ್ಲ, ಕಾಂಟ್ರಾಕ್ಷನ್. ಇಂಟರ್ಮಿಟೆಂಟ್ ಫೀಟಲ್ ಆಕ್ಸಿಜನೇಷನ್ ಕಡಿಮೆ ಆಗ್ತದೆ. ಅವಾಗ ಇಫ್ ವೆಲ್ ಆಕ್ಸಿಜನೇಟೆಡ್ ಫೀಟಸ್ ಟಾಲರೇಟ್ಸ್ ಇನ್ಸಲ್ಟ್ ಟು ಆಕ್ಸಿಜನೇಷನ್, ನೋ ಹೈಪೋಕ್ಸಿಯಾ, ನೋ ಚೇಂಜ್ ಇನ್ ಹಾರ್ಟ್ ರೇಟ್. ದಿಸ್ ಇಸ್ ನಾರ್ಮಲ್. ಬಟ್ ಇಟ್ ಇಸ್ ಅ ಕಾಂಪ್ರಮೈಸ್ ಫೀಟಲ್ ಲೈಕ್ IUG ಆರ್ ಪ್ರೀ ಟರ್ಮ್ ಫೀಟಸ್, ಇಫ್ ಆಲ್ರೆಡಿ ಪ್ರಾಬ್ಲಮ್ ಇದ್ದಾಗ ಈ ಮಧ್ಯದಲ್ಲಿರೋ ವೇರಿಯೇಷನ್ಸಿಂದ ಇಟ್ ಕ್ಯಾನ್ ಕಾಸ್ ಫೀಟಲ್ ಹೈಪೋಕ್ಸಿಯಾ ದಟ್ ಕುಡ್ ಲೀಡ್ ಟು the brain needs glucose and oxygen most. So that brain injury can occur, that leads to deceleration on decreasing fetal heart rate that will be seen on tachography. So consequences bandu metabolic acidosis, neonatal encephalopathy, hypoxic ischemic encephalopathy, long term sequelae, cerebral palsy. So what are the methods of intrapartum fetal surveillance? Intermittent acceleration of fetal heart sound can be checked by handheld Doppler or death itself. So routine monitoring for auscultation. Low risk cases ಅಲ್ಲಿ first stage of labor you can do it every 30 minutes. Second stage every 15 minutes it needs to be done for low risk cases. So low risk ward every 30 minutes. First stage, second stage every 15 minutes. In high risk ward, first stage every 15 minutes, second stage every 5 minutes. Cardiotocography, high risk pregnancies ali. Scalp pH monitoring, scalp stimulation, pulse oximetry. All these are the things that could be done for intrapartum fetal surveillance. Auscultation is to be done for a whole 1 minute. If it's abnormal, fetal heart sound is monitored for more than 3 contractions. Okay, cardiotocography is same as that equipment which is used for NST. It has a monitor and 2 transducers, one for fetal heart rate and one for contraction. 2 graphs are traced, fetal heart rate and uterine contraction. Normally it is 110 to 160 beats per minute. Bradycardia is less than 110, tachycardia is more than 160. Causes for bradycardia is head compression, fetal hypoxia, congenital heart block. Tachycardia more than 160 causes could be maternal fever, chorioamnionitis, beta sympathomimetics and fetal compromise. Baseline variability, irregular fluctuations of fetal heart rate including acceleration and deceleration. Normal variability is 5 to 25 beats per minute, which indicates normal umbilical cord pH. Normal variability 5 to 25 irutte. Absent or decreased variability is most reliable sign of fetal hypoxia. Variability of fetal heart rate, as we saw before only. Fetal acidemia predicts umbilical cord acidemia. Requires one more comorbid finding to categorize into 3. Causes could be for this decrease variability kadme irodike. Maternal causes analgesics, sedatives, magnesium sulfate alla. Fetal causes are fetal compromise, fetal hypoxia, fetal acidemia. Okay, prematurity. Avaga variability of heart rate will be less. Sinusoidal fetal heart rate pattern, frequency of waves 2 to 5 cycles per minute for more than 20 minutes. Fetal anemia, RH incompatibility, parvovirus B19 infection, vasa previa and twin to twin transfusion syndrome. At that time it requires immediate C-section. Criteria for sinusoidal pattern bandu fetal heart rate is 120 to 160. The amplitude is 5 to 15 beats per minute, frequency is 2 to 5 cycles. Absent deceleration, oscillation of the sinus wave, no use of drugs or narcotics. Ishtidaga, it's category 3 tachography. At that time we take them for cesarean section. Deceleration is drop in fetal heart rate by 15 beats per minute, lasting 15 seconds to 2 minutes. Prolonged deceleration, isolated deceleration lasting for more than 2 minutes but less than 10 minutes from onset to return to baseline. Causes could be oxytocin or misoprostol, supine hypotension syndrome, cervical exam, analgesic use. Sinusoidal RH incompatibility, parvovirus B19 infection, vasa previa syndrome. Deceleration, I told you the causes. So management, stop oxytocin because with contractions in hypoxia. Oxygen inhalation mask. Left lateral position. If no recovery, turbutal line to relax the uterus. If fetal heart rate dips for more than 10 minutes, indicate change in baseline fetal heart rate. Types of deceleration bandu gradual onset, U-shaped dip on cardiotocography, early deceleration or late deceleration, sudden onset and variable deceleration. So see here, early deceleration, gradual decrease in fetal heart rate reaching its nadir in 30 seconds. Onset and end of decreased fetal heart rate coincides with uterine contractions. Nadir is the lowest point which coincides with the highest point of uterine contraction. So if it coincides like this, usually benign. Head compression, vagal stimulation. So deeply gradually dip ಆಗುತ್ತೆ and it coincides with joint contraction. That is early deceleration. That is normal. It might be due to head compression because of vagal stimulation. Whereas late deceleration is onset of dip later than the uterine contraction, begins at peak of contraction due to uteroplacental insufficiency. This happens. Variable deceleration is dip as variable. ಅದು uterine contraction ಜೊತೆ ಕನೆಕ್ಷನ್ ಇರಲ್ಲ. This happens in cord compression, polyhydramnios, postpartum pregnancy, velamentous insertion and all of this. Categories ಬಂದು we were telling category 3 is dangerous. So category 1, 2, 3 ಇರುತ್ತೆ. 1 is reassuring, normal. So fetal heart rate is 110 to 160. Variable decelerations will be there. Not variable, sorry, early deceleration will be there, and variability will be there 5 to 25. Fetal heart acceleration 2 ಇರ್ಬೋದು. Category 2 is quite suspicious. 3 is non-assuring, that is sinusoidal ಇರ್ಬೋದು, absent or decreased with one of the following: late deceleration or variable deceleration, bradycardia. ಅವಾಗ immediate C-section ಕರ್ಕೊಂಡು ಹೋಗ್ತೀವಿ in utero resuscitation. Stop oxytocin, let the patient left lateral position in oxygen inhalation, ಕೊಟ್ಟು IV fluids ಕೊಟ್ಟು terbutaline if needed. Other methods of fetal scalp pH monitoring, scalp stimulation, oximetry.